Good afternoon and welcome to this month's Northern Virginia Health Policy Forum. I'm Jim Scott, President and CEO of Applied Policy, and I'll be your host today. My colleagues and I host these gatherings to share information and exchange ideas with you on important health policy issues. 1 in 10 Americans today, almost 40 million people, have diabetes. 1 in 5 of those individuals are unaware that they have the disease. We are privileged today to have with us 3 individuals who are on the front lines of the fight against diabetes and who are working to help those who have the disease. Today, our panel will discuss what is being done at the federal level to reduce the prevalence of diabetes, how the Centers for Medicare and Medicaid Services is working to provide access to adequate and affordable health care for people with diabetes, and what is being done about the high cost of insulin. Today, I'm joined by Lisa Murdock, Chief Advocacy Officer at the American Diabetes Association, Rob Goldsmith, Director of Advocacy and Policy at the Endocrine Society, and Kate Thomas, Chief Advocacy and External Affairs Officer at the Association of Diabetes Care and Education Specialists. If you have a question to ask one of the panelists, please put it in the chat and I'll try to work it into the program. So there's 4 main issue areas that we want to cover today: insulin affordability, CMS and Medicare policy, federal programs, and Medicare diabetes prevention programs. So let's start off with insulin affordability. Insulin affordability is top of mind for people with diabetes, and 1 in 4 insulin users said the cost has impacted their insulin use, and many others are cutting back or skipping doses, putting their lives at risk. So Lisa and Rob, we understand that the co-chairs of the Senate Diabetes Caucus have introduced bipartisan legislation to lower the cost of insulin. Can you tell us about what that legislation would do? Let's start with Lisa.
Sure. So the legislation contains several components. First, it works by ensuring insurance plans and pharmacy benefit managers can't collect rebates, which drive up the cost of drugs at the point of sale on insulins that roll back prices to the 2006, actually it's 2021 now, Medicare Part D list net price. So that information was accessible and from Medicare, and therefore that change was made in the legislation. It also makes insulins eligible for cost sharing protections, including waivers on applicable deductibles and limiting copays or coinsurance to no more than $35 a month. And I think the other issue is that we're ensuring that patients pay no more than that group and individual market health plans. Patients who have those plans pay no more than $35 a month for at least one type of insulin per class. It's important that we're looking at this in a multi-faceted approach, because some people have insurance and some people don't, and we want to make sure that we're putting downward pressure to bring the prices of insulin down, not only for people who have insurance, but for people who don't, or people who are underinsured. Rob, do you want to add to that?
Yeah, that's a great overview, Lisa. Thank you. The main things that I'll add here, I think first off, this legislation would be a huge victory if it passes for people with diabetes. The insulin copay cap alone, I think, is extremely significant. If you are on Medicare or private insurance, this copay cap is going to drastically lower the out-of-pocket costs that you're going to pay for this life-saving medication. It's going to ensure that you pay no more than $35 per month for insulin. Lisa also talked about the provision related to rebate reform and lowering list price. List price of insulin has been a huge problem for some time now. The list price of insulin tripled between 2002 and 2013. More recently, it doubled I think it was between 2012 and 2016. And I mean, really, this has been going on for such a long time, and there have been numerous congressional investigations and congressional committee hearings about this. And one of the common themes that we have seen as one of the reasons for why list price keeps going up is this issue of rebates. All across the drug supply chain, you have these different entities, the pharmacy benefit managers, the insurance companies who collect rebates. The rebates go down through the supply chain system, and it essentially drives up list price. And so, I think what this bill would do is kind of get at the heart of that problem, while also providing cost sharing protection and insurance protections for patients to ensure that they can access these insulins. So really, by providing, I think, these incentives, the bill sponsors believe, the Endocrine Society believes, we all believe that it will result in a significant price reduction of insulin. So again, a huge win for people living with diabetes. And that is why I really think it is so important that Congress passes this legislation immediately.
And Jim, if I could jump in on that too, just to echo what Lisa and Rob said, I think as we're looking at the complexity of drug pricing in the US and how Congress is trying to approach this, really having this carve out for insulin that would allow people to lower their out-of-pocket costs with this straightforward piece of legislation that would have an impact on people living with diabetes who require insulin to live. We're happy to see this solution going forward in Congress and having some consensus here, because as Rob and Lisa said, we really think there is going to be a difference. And so just echoing our support for this effort.
So Rob, realistically, what are the chances of this actually, passing Congress and getting signed by the president?
Yeah, a very, very good question, Jim. So again, this is a bipartisan bill. So it is going to need the support of both Democrats and Republicans in order to pass the Senate. And I think one of the key things that we are still waiting for regarding this legislation is what's called the Congressional Budget Office score, the CBO score, which is an estimate of how much the legislation will cost. And that will really be key, I think, particularly on the Republican side of the aisle, to determine how many Republicans would support this bill. There are several Republican senators, just news that came in this morning, actually, that I just saw, several Republican senators that are keeping a very open mind about supporting this. But I think that CBO score is going to be key in order to determine what kind of support we can get for this from that side of the aisle. So again, it will need to be the support of every Democrat in the Senate and at least 10 Republicans, because this will go under regular order. It will not, it'll be under the regular Senate process, and it will need 60 votes to pass. So again, we're working very, very hard to advocate for passage of this bill. We actually just went out with an action alert to our members all across the country, asking them to contact their senators, urging support. So we're going to be definitely doing a lot of work here in the next few days to try to get this bill over the finish line.
If I could also just add that this is an issue that resonates across the diabetes community. In the last month, we've had 60,000 advocates take action through our engagement platform to their members of Congress. This is an issue that's foremost in people's minds.
Yeah.
And then, Kate?
I was just going to say, speaking with that collective voice and really engaging all of our advocates across different organizations within the diabetes stakeholder community to show Congress that we're speaking with that collective voice.
So there's a lot of high-priced drugs that have been in the news, and fighting high drug prices overall has been a big issue. What is so special about insulin that makes insulin an even higher profile issue among all the expensive drugs?
Well, I think what Rob mentioned earlier, and that's the increase we've seen in insulin pricing without really explanation. Rob mentioned the statistics of tripling in a time frame. And that's what we're continuing to see. It's also a life-saving medication. You can't live without it. So if people with diabetes, we know 1 in 4 people with diabetes are rationing or skipping doses in order to pay for other basic life essentials. That's a real problem in households across the country.
Let's turn to CMS and Medicare policies.
Looking at coverage for devices. So we are always challenged with Medicare policy keeping pace with changes and innovations in diabetes technology, whether that be continuous glucose monitors, insulin pumps, automated insulin delivery systems. So what we've been doing is advocating for better coverage for continuous glucose monitors. We did have some policy wins here previously. People, in order to be eligible for a continuous glucose monitor, individuals had to demonstrate that they were checking their blood glucose via a finger stick 4 times per day, even to be eligible to get a continuous glucose monitor. And with the nuances of Medicare policy, of course, test strips were only covered for people testing 3 times per day. So really causing some confusion. But we and a lot of other stakeholders in the diabetes community worked with the medical directors for the durable medical equipment Medicare administrative contractors to update their local coverage determination to make some improvements to improve eligibility for CGM or improve access and expand the pool of people who would be eligible for CGM. So we're still working to push back on making some further improvements there, working with CMS to see if we can expand coverage to all people with type 1 and type 2. People who are, there's a requirement that people be on multiple daily injections of insulin in order to be eligible for CGM, and we're trying to work around that. We know that people may not be taking insulin 3 times per day. Maybe they're on a basal insulin, which requires taking insulin 2 times per day or another medication, so wouldn't be eligible. So just removing some of those barriers to eligibility. That's something, getting technology in the hands of people who need it to help reduce risks. Sorry, that was a lot on my part, but inviting Lisa and Rob to also weigh in.
Yeah, no,
Go ahead,
thanks,
Rob.
Kate. I was going to say, Kate, thanks. That's a really great summary of all those issues. I think, certainly we've been also supportive of many of the things that Kate was talking about. DSMT, a very important issue for us. And, in terms of diabetes technology, I think the point that I'll just add here is that, diabetes technology has come a very long way in a very short period of time. And, we really think that there should be no barriers to accessing this technology based off of a patient's situation. So, we certainly also weighed in on the local coverage determination issue. And, I think, really it's going to be something we're going to be continuing to look at very, very closely. And one other thing I'll also mention is that we have advisors that sit on the CPT and RUC advisory panel, the American Medical Association. And I know that this is something that continuously comes up at those CPT and RUC panel meetings. And so, something that we have been weighing in on there as well. So.
And in terms of coverage equity, the ADA is also looking, and I know about what's happening in Medicaid across the country in terms of coverage for CGM. We've had some studies commissioned looking at 2021 data on pharmacy and medical benefits claims data. That data has shown significant disparity or gaps between what's covered in commercial plans and what's covered in Medicaid. Unfortunately, the states that have the highest rates of inequities are also the diabetes belt states, as you can imagine, where the rates of diabetes are the highest in the nation and coverage for the devices is the least. Our survey or our data shows that states with a larger population of Black Americans are generally associated with lower rates of CGM utilization. And that's something we need to change. Your coverage shouldn't depend on what kind of coverage you have and what your race and zip code are. And that is unfortunately what's happening in the United States right now.
Thanks, Lisa. An important part of diabetes management is reducing the risk of diabetes-related complications, specifically complications that lead to vision loss, amputations, etc. Can you speak to the work being done in this area? Specifically, Lisa, can you tell us about amputation prevention?
Sure. Well, unlike other diabetes complications, the rates of amputations are on the rise, which is really troubling. Every 4 minutes, someone in the United States has an amputation. That's a 75% increase over the past decade. And 60% of the amputations are non-traumatic amputations related to diabetes. On the really sad figure or the troubling statistic here is that 85% of those amputations are preventable. And because people are not getting the care they need, particularly we just talked about in certain states or amongst certain zip codes, African Americans, Black Americans are 4 times more likely to undergo amputation than whites, and Native Americans face amputations more than twice as often as whites. This is something that we need to change. Some of this is due to provider and patient unawareness about the interventions that can be undertaken. As a result, referrals for screenings and interventions that could be used aren't done. There's a perception in a community that we're finding that diabetes or amputations are an eventuality. And that's a paradigm we need to change. ADA looked at it, building a Health Equity Now platform in 2020, along with many other organizations. How can we reduce those disparities? And the right to avoid preventable amputations is on that list, and it's something that we take very seriously and needs to change.
Rob, thoughts on amputation prevention, or Kate?
Yeah, I had a thought. I mean, it's referred to, I think there's a quote from Dr. Dean Schillinger that it's amputations are a mega disparity. And so speaking from the perspective of diabetes care and education specialists who are working with people with diabetes, our focus is on that self-management piece and reducing the disparities that exist in terms of access, like we were discussing, technology, telehealth, services, everything that the person needs to best self-manage their diabetes. So yeah, that's why we're trying to build awareness around diabetes self-management, education and support as a benefit for people, get people connected to providers, inform providers where these disparities are and how to intervene. So Lisa, I think you covered it so well, but just echoing some of that.
Yeah, I would definitely agree with all of that, I think. And I know we're going to talk about this a little bit later, but I think prevention programs, I think, are really critical here, and trying to avoid all of this from happening and making sure that we're preventing the onset of type 2. And yes, I think, we want to do everything that we can from the onset to make sure that this doesn't happen. So.
And then Lisa, what's being done to improve access to diabetes self-management training, that DSMT that we've heard about, and also care via telehealth?
And I'd really invite Kate to hop in on this conversation too. But let's just talk about telehealth and it's the importance that it's played during the pandemic. Telehealth has allowed people with diabetes to access care in the safest possible setting. And we want to make sure that that continues so that people aren't necessarily put in at-risk situations. And many people still don't feel comfortable going out in crowded facilities or medical appointments. So we'd like to see telehealth be made or extended and potentially be made permanent, to allow that to continue. Access to diabetes self-management training is a key part, as I think Rob and Kate have both mentioned, to avoiding the complications that we've talked about, including amputations. People need to know how to take care of themselves and be enabled with the tools to do so in order to maintain good diabetes control and maintain good health. And Kate, I'll ask you to jump in on diabetes self-management training access.
Yeah, thank you. I covered a little bit, but a few things that we're doing, multi-pronged approach. We've got a piece of federal legislation called the Expanding Access to Diabetes Self-Management Training Act, which looks to make some necessary improvements to this covered benefit, adding some flexibility for people. There's a allotted number of hours that the beneficiary has to access DSMT within their first 12 consecutive months. And there's not a lot of flexibility there. You can't carry over hours if you don't use them. So looking at things like that, expanding the list of providers who can refer for the service. So right now, if you showed up at the emergency department with a diabetes related complication, that ED provider couldn't refer you for DSMES or DSMT. And that's really problematic because we're missing so many people in the health system as a result of this. So we're pursuing legislative action, and we're also looking at regulatory activity too, working with the agency. As I mentioned, that RFI in the Medicare Physician Fee Schedule proposed rule provides an opportunity to to request improvements to the Medicare benefit for diabetes self-management training without having to go the legislative route. And we'll see what CMS has within their purview. And then recently, the Academy, ADCES and the ADA, we are both accrediting organizations for DSMES programs. It's how it's structured as the Medicare benefit. And so there are standards that govern that service. And so we work together on revising those standards and making that, reducing administrative burden for providers to make sure that it's a benefit that can continue to be easily accessed and provided. And then one more point with regard to telehealth. We've learned so much in terms of telehealth. We've seen for diabetes self-management, a reduction in no-shows and people keeping their appointments and not having those barriers of transportation or getting somebody to give you a ride or multiple appointments on the same day that cause, or different days that cause, you've got to have somebody help you with that access. So we've been really pleased. There's some nuance in terms of coverage for DSMT is provided by different types of providers, and not all of them are considered eligible telehealth providers. So we've been working on that with both CMS and Congress to address that. But also for technology, people are on CGM. Right now, there are in-person visit requirements every 6 months. We'd love to see that change to virtual telehealth appointments to reduce barriers there on the technology side too. So
thanks, Kate. Access to advanced diabetes technology, like you just mentioned, with continuous glucose monitors, insulin pumps, and automated insulin delivery systems are critical to managing diabetes. What does the landscape look like for coverage, both with CMS and through other payers? So let's start off with you, Kate.
So we covered a lot of Medicare coverage, working on a few different things, again, improving access to CGMs within the Medicare program. So working on continuing to update that local coverage determination, making sure that there are those necessary changes made to, as Rob said, I think so well, that everybody's got access, that there are no barriers to access. We're also working with some groups to look at the national coverage determination for insulin pumps and kind of looking at that through the same lens. What are the barriers there to people getting access to insulin pumps who need it? And then automated insulin delivery systems, really helping to make sure that the coverage policies are keeping up with the changes in technology. So there's not lag time in coverage for some of those. And then I know Medicaid, at least I'm sure can speak to this much more detailed than I can, but Medicaid, there are challenges in every state. And we're seeing some trends in terms of CGM coverage and AID coverage being covered as a pharmacy benefit for different Medicaid programs. That seems to be an easier pathway for access to many. So looking at all of those different things. But Lisa, if you wanted to weigh in on anything landscape related, I'd love to hear your perspective too.
Sure. We did a survey of Medicaid programs across the country in terms of their coverages, particularly for CGM, to see what utilization controls were in place and identify barriers that patients were experiencing. As Kate said, there were some barriers for patients that weren't able to access devices through pharmacy benefit. Sometimes devices could only be prescribed by endocrinologists, and there were very few in states who to see and get those prescriptions for Medicaid patients. Other barriers were things like documentation of hypo and hyperglycemia, or documentation, as Kate mentioned earlier, about the multiple daily testing or the changes in dosage for administration of insulin during the day. We've looked at all of those and put a map basically of how we're going to approach this and attack this problem in states across the country. We do want to increase utilization of those devices in Medicaid patients. And we've made some progress initially. Pharmacy benefit, as Kate mentioned, has been a good pathway for states to pursue. And it seems to be it's something that they're more amenable to doing. But we have other barriers that we still need to conquer, and we're looking at them on an individual basis and going after them as we can. It's a major campaign for the American Diabetes Association. Looking forward to continuing it next year in the legislative formats.
So, Rob, in your view, has CGM become the standard of care these days?
Well, I mean, I don't know I mean, I would certainly, my response to that is, the Endocrine Society has clinical practice guidelines on how, when appropriate CGM use is needed. And so I wouldn't want to speak to, get into the specifics there of when CGM is appropriate versus when it isn't appropriate. But I think what I will fall back to is, how this is rapidly changing and how, we're seeing, disparities with CGM access that certainly need to be addressed. And I think, ADA is doing some really, really great work here to try to determine what those disparities are. And, I think that the diabetes community as a whole is really wanting to look into this issue much more closely. So.
If I could just add that ADA has standards of care as well. And I think, but what we can say is that CGMs provide significant and potentially life-changing benefits for people with diabetes. We know that individuals with type 1 and type 2 diabetes who use CGM are shown to have less hypoglycemia, and they experience a reduction in their average A1C. So we, while saying it is a standard in treatment is something we probably would need to point to our standards of care for, as Rob said, I mean, I think there are strong benefits that we can talk about for people who utilize CGM. It allows devices to closely track glucose levels with adjustments for insulin dosing, and it changes lifestyle for people with diabetes. So it is a valuable tool, and we want to move away from situations where people in certain zip codes and have certain health insurance coverage are not getting access to the same devices.
Kate?
Adding to that, time in range is also another really big metric for diabetes management. So it's your time spent within your target blood glucose range. And CGM is a really critical tool for being able to measure this and assess time above range or time below range. And we're seeing really improved outcomes tied to time in range, and just one more tool in your diabetes management arsenal and your clinical care arsenal to be able to self-manage your diabetes.
Thanks. Yep, I agree. Physicians need access to all the treatment modalities, and it should be for all the patients, regardless of their zip code, and then without insurer second guessing whether or not the patient needs this. And then also, I think complicating it is the Medicare's DME benefit category is written into the statute, and their regulations still reference an iron lung. And so CMS is really struggling, and the manufacturers, I think, are struggling to continue to manufacture devices that meet the same requirements as an iron lung would have to meet. And it's probably time to think of that differently from a statutory level. But moving on from Medicare, what other federal programs or activities do you think we ought to be aware of? Let's start with Rob.
Yeah, no, thanks. Really, really great question. And I think actually what I'll start with is some recent work recent report that recently came out that really highlights a lot of these existing federal programs that are really, really important to diabetes care and diabetes prevention. The National Clinical Care Commission was a congressionally mandated commission that was tasked with evaluating and making some recommendations to improve federal programs related to diabetes care. And there were several Endocrine Society members that were on the commission, including the chair of the commission, Dr. William Herman. And the commission's report really has some very detailed recommendations to address the ongoing diabetes epidemic. Specifically, there's recommendations to provide more funding for some different programs that I think are really, really important. One of them I'll speak to is the Special Diabetes Program, commonly referred to as SDP. It's a program that addresses both diabetes prevention and diabetes research. And essentially it was created to advance research for type 1 diabetes and also to provide treatment and education programs for type 2 diabetes within American Indian and Alaskan native communities where you see some of the highest rates of diabetes. So SDP is a program that needs to be reauthorized by Congress. It's actually not part of the annual appropriations process. It's separate from that, but it does need to be reauthorized and funded. Current funding actually is still going. Funding for the program expires next September 2023, but this is definitely going to be something where you're going to see our organization and a lot of other organizations across the diabetes community advocating for a full reauthorization of SDP. Another program that I'll mention that's really important is the National Diabetes Prevention Program. You know, again, it's important to say this, you know, type 2 diabetes and other chronic conditions can be prevented with evidence-based programs, you know, that look at facilitate things like healthy eating and being physically active. And National DPP is a really great program that has shown tremendous success in delaying the onset of type 2. So, you know, those are just two examples where I think, you know, programs that need more support and more funding in the coming years. So.
Thanks, Rob. Kate, anything to add?
Yeah, I dropped the National Clinical Care Commission report into the chat if you want to take a look at it. As Rob said, this is really an attempt to look across the federal government at all federal programs related to diabetes and diabetes prevention. And so we view this as a playbook. It's got everything that we talked about today, recommendations for what agencies can do to make improvements, whether that be at the Medicaid level, insulin affordability, device access, everything, services, everything is in there. So it's worth a read. It's 192 pages, which isn't terrible for a federal report. They've got some cliff notes in the back. So take a look if you'd like to take a deeper dive into some of these policy recommendations.
Lisa, any thoughts?
Again, I think as Rob and Kate said, it is, we're very much in alignment with many of the principles, and particularly the health equity principles that mirror our own Health Equity Now platform.
Thanks. And so let's move on to our final topic, the Medicare Diabetes Prevention Program. We talked about improving access to diabetes and reducing complications, but are there efforts in place to reduce the prevalence of diabetes in the first place? Kate, do you want to start off?
Sure, and Rob really set the stage with his reference to the National Diabetes Prevention Program. And so the Medicare Diabetes Prevention Program is an expanded model under the Center for Medicare Innovation, and it was established in the calendar year 2018 physician fee schedule final rule. So the first programs, I think, launched on April 1st, 2018. And it's really to prevent type 2 diabetes among individuals at high risk for developing diabetes based on these evidence-based lifestyle change programs. And so we're a few years into the MDPP, and enrollment remains low. So I believe in the last evaluation report, which covered data from 2018, it was published in 2019, I think something like 2,248 Medicare beneficiaries participated in the program, which when you're looking at millions and millions of people with prediabetes, that's such a low number. And there are still some disparities in terms of who's accessing the program. I think 74 or 75% of enrollees in the MDPP were female, and 75% of the beneficiaries were white. And we know that that is not what the breakdown is. We know that there are disparities in prevalence and access. So really a lot of our groups that have worked together, Diabetes Advocacy Alliance is one such group that's looked at improvements to the Medicare Diabetes Prevention Program and made some recommendations, continued conversations with both CMS, CMMI, and the administration to look at things like removing the once per lifetime limit. So if you start the MDPP right now, you can't continue it or restart it if you stop outside of the public health emergency. And so we would be looking at that, better alignment with the national DPP. There are some differences in the programs which make it really difficult from the supplier perspective. Looking at other things like payment structure, which is problematic. There's a lot of burden on the suppliers. And so overall, looking at things like improving supplier enrollment and then improving beneficiary participation. And I'd invite Rob or Lisa to add anything.
Yeah, I mean, the one thing that I'll add here is I think if you can look at the provider supplier map on CMS's website, and if you look at that map state by state, you will see that there are these geographically these areas where there's really no access to this program, and that is a really, really serious problem. And I think that's why we're looking at all of these different ways to improve and expand the program. That's why there's legislation that's been introduced, the Prevent Diabetes Act, to try to expand access to this program. And so I think there's a lot of work here to be done to strengthen MDPP.
And to Rob's point about the Prevent Diabetes Act, right now in the MDPP, virtual suppliers are not able to participate as suppliers. So they are able to participate in national DPP and through commercial payers, but not in MDPP. So the Prevent Act would look at expanding the MDPP to include these virtual suppliers, because that's really how you expand your reach and reach these millions of people, is making sure that it's available in all modalities.
Thank you. We have a couple of questions in the chat, and so I'll go ahead and ask them, and whoever thinks they know the answer can go ahead and speak up and take them. But the first question is about because of the type 2 diabetes is largely contributed by food insecurity and nutritional issues. What's being done to lessen food insecurity and improve access to better nutrition?
So the National Clinical Care Commission report breaks down a few different things. So they look at prevention of diabetes in the general population, prevention of diabetes in higher risk populations, and then diabetes treatment and complications. And so in this general population, they do have quite a few recommendations around food insecurity and just improving access to food for all Americans. And so there's some good policy recommendations that I would recommend you take a look at. We've been trying to elevate those. Yesterday, we did the Diabetes Advocacy Alliance, and Dr. Bill Herman, chair of the National Clinical Care Commission, did a congressional briefing to elevate some of those principles to lawmakers and to staff. So that's something that's really important. And then the White House is having this White House Conference on Hunger, Nutrition, and Health, and that's scheduled for September. And they're hosting a series of listening sessions to help inform those activities. And so our group, ADCES, the Diabetes Advocacy Alliance, and others I know are weighing in on some of these conversations. They're looking at people's stories. They want to hear from people who are impacted by food insecurity and some of these other issues that are happening and affect diabetes management and overall health. So getting some national attention there, both through the commission report and through the White House conference, but there are certainly other efforts in place as well.
Thanks. Lisa?
Just to underscore what Kate said, ADA has been working with the White House on this conference. So we're also looking at this at a state level, looking at school food policies, looking at how to deal with food deserts and food swamps in communities, how to incentivize healthy food in communities, and providing other prevention strategies, including access to recreational spaces. So there's a lot of work being done across the country at the federal level and also at the states to try to attack this problem, but it's a significant problem with not any one easy solution.
So last question is, while diet and exercise can sometimes cure type 2 diabetes, there's a need for a broader concern, especially for juvenile diabetes. We've talked a lot about the management of diabetes, but where are we on getting to a cure for diabetes?
That's a little above my pay grade. And I will just say that the American Diabetes Association just held its 82nd annual scientific sessions. There's some really good sessions available online for people to view about what the latest advances are in diabetes research for a cure for diabetes. It's something we all want, right? We all want to see an end to this disease. So I'd invite everyone to go online and look at our website and to pull some of the research or the presentations from that session. It was amazing. So.
Rob?
Yeah. I was just going to add, I definitely don't have the degree or credentials to really get at that question for you, but it's a really good one. And I'll also add too, in addition to the ADA meeting, the Endocrine Society just held their annual meeting as well. And also were some really, really great sessions that explored and talked about this issue in more detail. I know it's something that a lot of our researcher members are looking into very closely. So.
Thank you. So before we wrap up, I'd like to give each of you the opportunity to offer a final thought. What's the one most important thing out of your answers today that everybody ought to remember? And let's start with Kate.
That's a hard one, Jim. A couple of things. Diabetes is complex as a disease and when we're looking at diabetes policy. So it takes remarkable coordination at the federal, state, and local level, as well as communication between people with diabetes, providers, and others in their communities. So in order to tackle some of these huge issues, we really have to bring stakeholders together within the diabetes community, those on the periphery of the diabetes community, and speak as one around some of these aligned policy goals. I think the National Clinical Care Commission does a fantastic job of summarizing some of those big picture policy goals that we're all trying to achieve. But I think opportunities like this and continued collaboration really make the difference. And we've seen it shift policy too. So that's my main takeaway for today.
Thanks. Rob, what's your main takeaway?
Yeah, I mean, again, we've talked about a lot of really, really important issues, but I think really, we really, in a lot of ways, need to solve this insulin affordability problem. I mean, so many of these issues I think we can tackle, but we have to solve the insulin affordability problem. This impacts so many people living with diabetes, and I really see that as the number one takeaway here today that people need to keep in mind. So,
Lisa, you get the final thought.
Great. Look, there's tremendous, as Kate said, diabetes is a complex issue, but there's tremendous urgency. What's not complex is we need to do the right thing for people with diabetes. And that means that we need to make sure that we're addressing the cost of insulin, that we're making sure that people with diabetes have access to the tools and supplies, medications that they need in order to maintain good health and live healthily. Otherwise, we're just perpetuating a system that is riddled with health inequities, and that's not fair for anyone. People with diabetes enter this conversation already at a deficit. If you add other health inequities into the equation, it is just, we're setting people up to fail in terms of health, and that's something we need to change.
Yeah, thank you all. And my biggest learning today was that diabetes-related amputations are a mega disparity that ought to be addressed, and that seems totally unfair to me, and something ought to be done about it. So thank you all for joining us. To the audience and our panelists, thank you very much. And stay tuned for our upcoming health policy forums. You're on our list, so you'll get invitations. And we're working on the next one for sometime in August. And after we firm up the speakers, we'll be able to make an official announcement. So everybody have a great day, and please join us next time.